First of all, I have to say that the success of immunotherapy at the moment has been limited due to the fact that most of these patients have a low, what we call cancer immune set point, meaning that the threshold beyond which we can reinstate tumor immunosurveillance in a given patient might be variable depending on the genetics of the host, the genetics of the cancer, the comorbidity, the co-medications, the environmental factors, and all of these cues will influence what we call the cancer immune set point, which is a very threshold beyond which an immune response can ensure. And so the immune system of a patient can be governed by the microbiome. That's what the data seems to indicate. And this microbiome will influence, so not only the threshold, but also the duration, the intensity, and the strength of the immune system of a given patient. So now that we know that, what were the evidence that have been brought up so far and published by the colleagues and our team that support this contention? So first of all, we were able to show that antibiotics, broad-spectrum antibiotics, whether beta-lactamines or fluoroquinolones or tetracyclines can actually decrease the efficacy of immune checkpoint blockade. And those data now have been analyzed on more than 400 patients, lung, kidney, bladder cancer patients, even melanoma cancer patients. So this is more or less demonstrated in a larger meta-analysis that the antibiotics really impair the efficacy of the immune checkpoint blockade when they are administered about 1 month prior to the start of the antibody, the therapeutic antibody. So that's the first line of evidence. The second line of evidence stems from the fact that if you use an avatar mouse model, which is a transfer of fecal material into a germ-free animal, or into an animal that has been decontaminated using broad-spectrum antibiotics, then you expect the fecal microbial transplant coming from a cancer patient to colonize at least partially the host. And in that case, you can inoculate a cancer and administer treatment and analyze properly the impact of the gut composition, to the microbiome composition on the efficacy of the treatment in these mouse models. And so we were able to show in these avatar mouse models that we could almost predict whether a patient at diagnosis would be able to respond to PD-1 blockade based on the transfer, the mere transfer of his fecal his stools materials at the beginning into this avatar. So of course it's not black and white. We noticed that in 18% cases it was unpredictable. However, this means that the stool is at least one of the components dictating the efficacy of immune checkpoint blockade in tumor-bearing animals. Then the third line of evidence is based on the metagenomics based gut oncomicrobiome fingerprints, which are, the detailed sequencing of the whole microbiome of a given patient. So if we compare the responders from the non-responders using response criteria, best clinical outcome, or time to progression at 3 or 6 months, we can segregate and contrast the responding patients versus the non-responding patients to this therapy based on the alpha and or beta diversity, or if not, based on the predominance of, let's say, some immunogenic commensals as opposed to regulatory commensals. So we are, of course, these are it's a pioneering, burgeoning field, and we need to, if this is to become a true biomarker, we need validation cohorts of at different locations with different type of treatments, what we are trying to do at the moment. But I will come back to this notion later. But basically, what we would like to call GOMS, so gut oncomicrobiome signatures, appear to at least segregate at diagnosis the patients prone to respond or doomed to fail the therapy. And then the fourth line of evidence is more, what we knew about how therapeutics can alter the intestinal integrity, the epithelial barrier. We know more and more about the biology of the intestine, and it sounds like apoptosis, autophagy, necroptosis, inflammasome, ignition, all these very fundamental pathways seems to play a major role to regulate stem cell nest, to regulate absorption, and of course to impact on the systemic metabolism of the host, and as a consequence on the systemic immune system. So these were the four lines of evidence that we knew so far and that we accumulated through this publication over the last 7 years. So what comes next and where are we standing at the moment? So first of all, I would like to say that our governments, the French Ministry of Health Affairs and of Research, have supported us together with INRA at building up a consortium that is based on a culturomics potential that we had from IHU Méditerranée Infection with Didier Raoult, the head of the IHU, South France. So we have now the culturomics potential, meaning that you can cultivate the feces of patients onto different conditions, culture mediums, and you can, from that, align the whole, let's say, repertoire of commensals that this particular patient is hosting. We can also do, of course, the 16S and or the metagenomics sequencing of the whole microbiome of the same patient, and we will have complementary information vis-à-vis of the culturomics, and we can then see whether the patient has a signature that seems to indicate that he has, regulatory and or immunogenic commensals that could play a role during this immune stimulation. So the aim of this is to, of course, identify and map what are the important commensals in terms of, first of all, curing or re-establishing, restoring a normal integrity of the gut, and secondly, in mediating metabolomic or metabolite-based immunostimulation and cure the cancer at the end. So beside these efforts, we are of course trying to do causative relationship with the responses, so meaning that we need to identify new commensals in the dark matter. We have not been able to identify all the commensals, but now, thanks to the new technologies of culturomics, we can identify new commensals, let's say report it and do a deposit in a specific repositories where the whole community can access to these new commensals and can do a cause-effect relationship in different diseases, in different mouse models, to be able to bring up the proof of principle that these commensals are really mediating some kind of bioeffect, whether you're interested in stimulating the immune system or in contrast, eradicating the regulatory T cells or boosting the regulatory T cells. We are also very much involved in the metabolomic analysis. So this necessitates mass spectrometry and mass spectrometers of high quality equipment, and that enables to in different liquids, so ileum, colons, but also the plasma, the liver, the heart, and the omentum fat tissues. We can identify the metabolites that can be inferred from the administration of a given commensal, so that we have also a better view of what we are modulating when we are performing an oral gavage with distinct microbes. So it's important also to say that these microbes will be at some point combined together to give a single medication. And at the moment, several biotech companies are trying to figure out what would be the ideal consortium, the minimalist ecosystem that would be able to kill two birds with one stone, re-establish a normal abiosis in these cancer patients, and go further, trying to boost the immune system and to synergize with the therapies. So, of course, we are not sure one size will fit all. First of all, some cancer patients might have specific dysbiosis depending on the cancer type. Secondly, some therapeutics might also switch on and off or modulate the microbiome composition. And it will be of interest in the near future to distinguish what is the participation of the disease in the dysbiosis and what is the involvement of the therapy in modulating this dysbiosis. And of course, we would like to propose at the end maybe a personalized therapy with the ideal microbiota of the patient, but more probably we will be able to come up with a mixture of commensals that will be able to repair the intestinal barrier of diseased patients, and also maybe another consortium which will be able to reinstate humoral and cellular immunity against cancer. And this is presumably also something of importance. Now, I would like to finish in prophylaxis. So, of course, we are now more and more interested in looking at what diet is doing on the microbiome composition. We recently heard from the colleague in Israel, the Weizmann Institute, and my colleague Jenny Vargo at MD Anderson, that the diet may impact on the microbiome, and conversely, the microbiome will impact on the diet. Metabolism, so it's an intertwined relationship that is not easy to dissect at the first place, but presumably we will go into a direction where the best commensal, the best mixed of the minimalist ecosystem will have to be combined with an appropriate diet in order to enable these commensals to establish, colonize in a long-term process and not just a short-term process. And so at the moment, the investigators are trying to at least understand in cancer patients what kind of diet, whether it's fasting, intermediate fasting, or ketogenic diet or fiber-enriched diet. So at the moment, there is an agnostic view on what to do. More importantly, we will have to monitor plasma and or tissue related biomarkers to be able to have a pharmacokinetic assessment of what the diet is actually introducing in the host, so that we will have a hallmark biomarker of bioactivity of the diet, if I can say so. And we should be in a position where we will know that the diet has induced complete bioactivity and biology, and we will know how the gut microbiome of the host will have been modified. So this is what currently the efforts are redirected to. And we have hope that some foundations that are currently helping the academic institution are really in love with the idea of trying to get the patient participate in his own cure by just doing its own biotherapy, by eating the right food composition, so that he will redirect his own microbiome in towards an optimal ecosystem. That's one thing that we are thinking about. And then the second thing, of course, is try to understand whether the microbiome can cause cancer, so can cause inflammation, and from chronic inflammation can increase the propensity of a given subject to increase his likelihood to develop a cancer. And so we have, at the moment, we are launching the Oncobiome Age 2020 network in Europe. So this is a wide distribution of geographical distribution of all the investigators are trying to have collection of feces prior to developing any type of cancer, and we will be in a position within the next 3 years, I think, to come up with the validation or the invalidation of the idea that a dysbiosis can actually cause cancer, or at least some cancer types. So with that, I think that there is a lot of impetus and enthusiasm from the biotech company and the big pharma now to come along with academics and also big hospitals to be able to really launch clinical trials that will either start from PD-1 resistant, anti-PD-1 therapy resistant patients that will receive either fecal microbial transplantation of responding and cured patients, or will get a mix of commensals or spores that will re-establish a proper ecosystem. So these are currently ongoing at the University of Pittsburgh, at the MD Anderson in Texas. In France, we have also MAD Pharma with the enema-based re-administration of biotic fecal materials. We also have Vedanta, who is coming up with an 11 mix of commensals that seems to be very broadly effective against wide ranges of mouse tumors. And there are also other investigators that try to now look at the phages that are inserted into the commensals. These phages they are viruses of the prokaryotes, so they might mediate an immunogenic or an antigenic response as effective as the one that we know for human viruses towards eukaryotes. So some interesting preclinical studies indicate that it could be the case, and that phages can be also another way. Phagotherapy could be another way to approach the diversity and to harness the diversity of the microbiome. And more to come, presumably also on the side of RK, which are far ahead, but that also may open the question of the inter-kingdom relationship and this interactive networking in our gut.